So now, anybody have any questions about the protons? We're breaking the clock here. Then we'll talk about some of my biases on how to treat prostate cancer. Yes, sir.
When will they determine, is there an age break off on this thing? You know, now that I'm 70, everybody telling me to start out while I'm 70, you know.
There isn't, in the sense that, you know, at 70 you're good for protons, and at 75 you're not. The assumption is that the longer you have to live. So again, we make certain assumptions about life expectancy. So if you're a healthy 70-year-old, I tell people I'm worried about you until you're 90. So I've got to show some improvement in that 20 years. So it might make more sense that if you've got that you may want to treat somebody, the younger they are, it makes more sense to treat them with protons, because of the later effects will hopefully improve, because we're not spraying the dose all over. And I shouldn't say that. It's a more conformal dose. You're not getting as much more tissues treated. But if you look at the data and prostate cancer treatment in general, whether treatment works or not, the cutoff is pretty consistently 65 to 70. If you have a good study, we're going to go over one, where you look at who benefits from radical treatment, whether it be radiation surgery or radiation of any type. Once you get up over the age of 70, it's very difficult to prove an overall survival advantage to the treatment of prostate cancer.
What did you say that again? What did you say?
Once you get over the age of 70, with randomized trials, in other words, where you had, I'm going to treat this group this way, I'm going to not treat, I'm going to do watch and waiting this way, and the treatment decision was made by a flippable coin in the NIH, it's very difficult to prove that these people live longer than these people. Now, these people that aren't treated, maybe the PSAs may wander all over the place, they do all sorts of stuff, but they live exactly the same length of time. So why am I treating a prostate cancer? There's three reasons that I treat cancer. I want to make you live longer, I want to make you live better, and if you have symptoms, I want to relieve them. So I can tell you that when I treat prostate cancer, generally I don't make symptoms better. And there are some side effects that you have to be willing to accept, mainly evidence, whether it be surgery or radiation. So if I can't make you live longer, then why am I treating you? So that is the whole argument for watchful waiting, active surveillance, whatever you call it. We have to prove that we're extending your life for all these other things to be worthwhile. Yes, sir.
Dismiss the insurance issue, but you know, if the prostate goes to a single nodule, you know, is it possible to use the protons on a single nodule? Studies have shown that it might enhance the survivability.
Right. And one of the things I always tell my residents, whenever they say this might, or usually when you read it is, in the headlines is, such and such treatment may improve survival. I said, always instead of say may not, because that's how sure they are. So, yes, if we get this machine working like we can, and we've got all these possibilities, we may find out that treating just a portion of the prostate may be a great idea to do. Unfortunately, it's probably not going to be known to help anybody in this room, including myself. I mean, that data is going to take a long time to mature. Now, you could say, I believe in, if we want to talk religion, if you believe in it and you want to do it, and you get somebody willing to pay for it, or you're willing to pay for it yourself, will we do it? Yeah, probably will. Because, when we say, okay, we're generating data, we can answer questions, but we don't know. So we can't, I as a physician cannot overpromise this. I can't tell you it's going to be the best of everything, because we don't know. And we don't know until we have the experience. And like I tell my residents, if you don't have 10 years in prostate cancer studies, you don't have it. Yes?
Can you tell us how many treatments you have to have with proton beam versus conformal?
It's the same. And you could say it's the same, and we don't know. Because if you look at the external beam literature, people are saying the standard radiation treatment for protons and photons is anywhere from 7.5 to 8 weeks.
That's daily.
Daily, Monday through Friday.
5 days.
5 days a week. People are looking at, are there some types of cancer that we can shrink that down? Because we're so conformal now. So we always have known that if you could treat a really small area, you can bump up the daily dose and get to the curative dose faster. So instead of getting 200 centigrade a day, why don't we give you 300? Well, we used to not do that because your rectum wouldn't tolerate it. your bladder wouldn't tolerate it. But if we have the technology to avoid all of those tissues, why aren't we doing it? Maybe the prostate will handle it just fine. And that's what we're looking at. And there is early data to suggest, and this is 5 to 10 year data, that this may be the way that we're going to go. And it could be 5 or 10 years from now. That's the way everything will go. We've done that in breast cancer, where when we were trying to conserve the breast, we said you had to have 5 weeks, and then we boosted around where the tumor was. For another week, be 6 weeks. That's inconvenient for a lot of people. It's expensive. So the people usually answer those expensive questions are the Canadians. So the Canadians in their health system said, well, we got some early data to suggest that maybe you only can do it over 4 weeks. So they shrank everything down to 4 weeks, and people do better. So all of our preconceived ideas about what was the best way to do things were kind of turned on their heads. But doctors are creatures of habit. If you were trained to do things a certain way, it takes a mountain of data to get you to change your mind. Because you assume that you're always doing it right. And you assume you're always doing it the best thing for the patient. And you have to look at it very objectively and say, no, maybe not. Yes?
You mentioned that you didn't believe or didn't do any PSA screening yourself. And I was wondering how you know if your prostate's healthy or not. I mean, how do you, at a certain age here in America, we are pretty traditionally screening for prostate cancer.
You said it a very key word in describing yourself. You say, we in America. The Europeans think we're nuts. They think we're absolutely crazy to be screening prostate cancer like we're doing. And they don't believe in it. And if you look at all of the data on prostate screening, it is not very convincing. Doesn't mean we can't do or shouldn't do it, but we're not doing it right. What we are causing is a massive overtreatment of prostate cancer in this country.
Well, how can it be?
What do you mean, how can it be?
People that I know in their 50s.
Well, let me put it to you like this. If you're diagnosed with a low-risk prostate cancer, and you are in the 65 to 70 age group, whether you choose surgery, radiation seeds, IMRT, prostate cancer, prostate implant, protons, or whilst you're waiting, in 10 years, you will look back and over 95% of the time, you will assume you made the correct decision because you're doing just fine.
Would you explain something when you say prostate implants? What's that?
So an implant is a way of delivering radiation where you have a radioactive seed.
That's right.
And so you know how you get a prostate biopsy, they put that probe up your backside and they put a needle up there? Well, when you do a prostate implant, you use the ultrasound to outline the whole prostate gland, and you see it as a series of slices, like you're slicing a loaf of bread. And then in the computer, you put that all back together, and you just decide where you want those prostate seeds to go. And then you come up with a loading plan, and you can do this either what they call high dose rate or low dose rate. In low dose rate, you just put the seeds in, and they stay forever. They peter out. They have a half-life of 60 days. If you're using iodine, a little faster. If you're using other elements, and it causes your PSA to come down, and it controls prostate cancer. If you do at what they call high dose rate, you go in the hospital, they put these needles in, and they run a high dose up there, and then they do a treatment just like you would do for a fractionated radiation. They usually do it that once they put them in and they keep you overnight, they do it the next day. There are a variety of fractionation patterns. So what that does is it concentrates the dose in the prostate. Very high doses of some part of the prostate, but the outlying area is totally spared, essentially. So I always tell people that all of your treatment decisions, and I'm not here to sell radiation by any means, but all of your treatments have certain known side effects and certain maybe side effects. And you have to be comfortable with what those are. And there's certain situations where I'll recommend a type of treatment because you're bringing in certain baggage already. So if I see a guy with a fairly good sized prostate and he's on Flomax and he's getting up 4 times a night to urinate, I tell him the last thing you want is an implant, because I'm going to make that worse. And if you're getting up 4 times a night, you're not getting much sleep, but I can probably make that 8 with a good implant. And that may last for 6 months. And some guys it lasts forever. That may be one person out of 200, but if you're that one person, you're not real happy with me. If I had told you that might happen. So I've had guys who, I told them, you know, I'm a really decent oncologist, but if I were you, I'd get that prostate out. Because if nothing else, you'll pee a lot better than you're doing now. Then your quality of life could go up because you get a good night's sleep, and you won't be heading to the bathroom every 20 minutes. And they think it's great. There's other people who, I tell them, yeah, you can have a prostatectomy, but, and we'll go over some of the data, because there's a good study here that we should all look at very closely. I don't want to go over it with you. But are you willing to have a pad 20% of the time? And if you're not willing to have that, if that's going to totally destroy you, then they shouldn't have a prostatectomy. But if you're willing to accept that risk, realize that most guys just urinate just fine after prostatectomy, and that's fine. But you have to be willing to accept the possible side effects. And I also tell people when I watch for waiting, I said, this is the treatment choice that has the least amount of side effects. But there's a chance that we'll miss a chance of curing it. Probably not, but we might. And you have to be able to live with that. I've had guys, and I was kind of an early adapter for prostate surveillance. So I would get a lot of people sent to me that didn't want treatment, and the guys just didn't want to mess with it. They said, fine, go to Redmond, do watch. And I had a guy, as I tell him, okay, we're going to do this, and what we're going to do is I'm going to see you. 3 months, we're going to get a PSA. We're going to get a PSA every 3 months for the first year. We're going to see where the trend's going. So, those guy fine. Okay. So I saw one guy, and he comes back, and he said, time for my PSA. I said, oh, yeah, it is. I hope it's good. He goes, oh, it will be. I've had it checked 6 times since I saw you last. And I said, you're not a good watcher waiting guy, because you cannot accept the risk, and you're so nervous about it that it's that quality of life issue is going the wrong way. And so I said, let's pick one of the 3 treatments, and unless you can quit checking your PSA, you're going to be miserable. So there's a lot of that goes on when you try to counsel someone on how to treat their prostate cancer. You have to kind of look them in the eye and say, okay, what are you willing to accept? And truthfully, for active treatment, if somebody is already impotent and they're not sexually active, I think the decision's a lot easier, because I think all of the treatments, they're all going to take that away to some extent. You have to be willing to accept it, because you're going to face it. And some people say, well, what are the chances? I said, well, I always look at it that your erections have a life expectancy just like you do. and treatment shortens the life expectancy of your erections, while it may lengthen your life expectancy of you as a whole. So things are going to go away sooner rather than later. And you got to be willing to accept that. And if you're not, I mean, that's your choice. I can't impose my values on you. I had a very interesting patient who, very early on in my career, who had metastatic prostate cancer. And when he came to see me, I radiated painful bony met, and I said, okay, now you need to start hormones. And he goes, no, I'm not going to do it. I said, well, this is just going to get worse. He goes, I know, but life without sexual activity is not something I'm willing to accept. So I followed that guy for probably 5 years with his metastatic disease. And he was on a lot of narcotics. And he said, this is how I want to live my life. And I said, fine, that's your choice. But I'm telling you, you're going to, because I know what we would have the same conversation every time. And I said, you need to know that this treatment will take your pain away probably for at least 2 years, But it probably won't make you live any longer, because hormone treatment in the metastatic setting, no matter when you give it, it doesn't really make the overall infant survival that much better. And that's how he lived his life. And I never had that happen again, but that was his choice, not mine. Yes.
Okay, I had seeds put in.
Uh-huh.
And then I had the surgery.
Uh-huh.
I'm still wearing pads, and I'm just wondering if I should have had either one, because,
well, I always tell people the time to ask those questions is before you select your treatment. I said, you have to be willing to be able to look back and say, I did all my due diligence. I did all my research. I talked to all the right people, and I made the best decision I could make for me at that time. And hopefully it goes well, but it might not. But if it doesn't go well, you have to be able to look back and say, okay, I did everything I could, and that's just the way the cards fell. Because that's how it is sometimes. Sometimes you do everything right, and you're the 1%. And there's no way to predict who that 1% is going to be. You know, obviously, if I knew I was gonna do an implant on somebody and they were gonna, you know, basically not be able to sleep through the night for 2 years, I would not do the implant. Now, I know there's certain factors, like how much Flomax you're using, how big your urinary symptoms, how big is your prostate. So I can screen out of that, and I can bring that number down as low as I can, you know, given this imperfect system that we have. But I can't eliminate it. And I've had guys that said, Doc, I'm doing this. I said, I told you there was a chance of this. And we talked about that. And I'm sorry it's happening to you. I'll do everything I can to relieve that. But that's the price of admission. That's the price of treatment. Yes.
Dr. Redmond, I want to go back.
Intervention.